Hi, I'm Dmitry Rozenberg from the University Health Network. It's a pleasure to be here for our journal club on April the 30th. We'll be discussing the paper titled Validation of Constant Work Rate Cycling Endurance Time for Use in Chronic Obstructive Pulmonary Disease Clinical Trials, published in the Annals of the American Thoracic Society in EPUB December 2023. It's a pleasure today to have co-moderator Mariana Hoffman with me today, who's a postdoctoral fellow at Monash University, Alfred Health in Australia, and is part of the web committee as well. Thank you, Dr. Antenor Rodrigues from the University of Toronto, Unity Health postdoctoral fellow, who will give us a 15 to 20-minute presentation and overview of the topic. And today we're delighted to also have our co-authors, Professor Richard Casaburi with us from UCLA Medical Center, and Dr. Alan L. Hamilton from the COPD Foundation, and also from McMaster University, who spent a lot of time and effort along with their co-authors. And it's a delight to be here, and we'll turn the floor over to Antenor Rodrigues to present. And then after the presentation, Mariana and I will co-moderate the session, and we look forward for questions from the audience. Thank you, everyone. And as a reminder, the presentation is being recorded. So if you can mute, that'd be appreciated. Thank you.
Thank you, Dmitry, for the invitation, and Mariana as well, and the ATS. Happy to be here discussing this paper. So I'll do my best. We can have a nice and smooth discussion about this. So just for our agenda for today, I'll have a quick background about the subject, objectives of the paper, and the main methods and results they used, then a conclusion, and then we can open for discussion. So just as a background, the constant work rate cycling test is now established for clinical research and to assess the effects of pharmacological and non-pharmacological therapies for exercise endurance in patients with COPD. Just to clarify the difference, so if you look at the graph on the left side, x-axis we have time, y-axis we have load. This is an incremental test, so we have a brief warm-up period, and then the load increases while the patient is cycling, and the test stops when the patient cannot tolerate the increasing load anymore. You usually have the outcome as the peak load or the peak oxygen uptake during the test. Again, that's for the incremental test. Usually for the constant load test, we select a percentage of the maximum load the patient tolerated, something around 75 to 85% of the maximum. And then the patient will perform a test where is the graph on the right side of the slide. Again, you have time on the x-axis, load on the y-axis, where you have a brief warm-up. Then the load is abruptly increased to the target load, which will represent 75 to 85% of the maximum the patient reached. And then the patient will cycle at that same load for as long as she or he can. And then the outcome for the constant workload test, one of the outcomes, and is what is studied the most on this paper we are discussing today, is the time the patient tolerates. So endurance time, how long the patient can cycle at that same fixed load. Also, it's important because to remember here, we always discuss FDA and research when we have new medications or new therapies. But for this case, the case of this paper we are discussing today, the idea here is to bring a new outcome for studies assessing the efficacy of therapeutics for patients with COPD, for instance, for bronchodilators or other medications. So in this case, we're not looking for safety, efficacy of a specific medication, but can we use a specific test, an outcome for a test to assess efficacy of interventions used for COPD? And the outcome we are discussing, which is endurance time from the constant workload cycling test, is not yet approved by FDA, despite being used a lot for research. So this study is building on many other studies this group of authors have been publishing. So, and mostly from this first paper they published, where they have a conceptual framework for the use of increased endurance time during the constant work rate cycling ergometry as a patient-focused outcome in COPD, and they support the rationale saying the constant work rate cycling test, the endurance time, is an appropriate candidate to measure test improvements in exercise endurance in COPD, mostly because the improvement in endurance time implies that that patient is capable of performing activities in everyday life for a longer duration without stopping. And they compare with the incremental test, which usually described as the gold standard for measuring exercise tolerance, let's say oxygen uptake or the maximum load the patient takes, which is very different, which is like if the patient was climbing up a hill that's always steeper and steeper, but that does not specifically translate to activities of daily living the patient wants to do or needs to do, like mobility or bathing or even go to the grocery stores. So the objective here was to demonstrate that the endurance time from the constant work rate cycling test is an appropriate exercise endurance measure in COPD. And to do that, they want to describe the measurement properties of the constant work rate cycling endurance time and discuss the use of this metric to evaluate the treatment efficacy in COPD clinical trials. So their population has been described before on this first paper, but briefly it includes patient-level data from previous published studies incorporating the constant work rate cycling performed to symptom limitation as an outcome measure. It includes 8 bronchodilator studies with more than 2,000 patients and 15 exercise training studies with almost 3,500 patients. Their database is composed by 71 variables per participant. Some variables are missing for specific participants, but they have most of it, which increase the power of their analysis, but includes demographics, spirometry, and exercise variables outcomes from the constant load and the cycling and the incremental cycling exercise test. You can see table 1 from the paper on the right side of this slide. There was no difference between the participants included in the bronchodilator studies or the exercise training studies. They also have on the supplement the comparison between patients randomized to either the active or the control group in the bronchodilator studies, and they were, again, similar, no statistically significant differences. The first stop they address on the paper is the constructive validity of the endurance time from the constant work rate cycling test. Where they are addressing is whether the instrument measures what it should measure. So in this case, an assessment of endurance, which is relevant to performance of everyday activities for the COPD population. So first, the first assumption is that for the constant work rate cycling test, the endurance time to be valid, right? The responses, the physiological responses during the test should be close to the maximum compared to incremental test. So this is the first analysis they report. So here on the table, you have from top down oxygen uptake, right rate, minimal ventilation, inspiratory capacity, and inspiratory reserve volume, Borg dyspnea, and Borg leg fatigue. So second column, you have the number of patients included for each of these analyses. And then we have the mean values for the constant work rate cycle test, the mean values for the incremental test, and then the difference between the two tests. Last column shows the agreement between the values. So for instance, first line, the agreement for the VO2 from the incremental and the VO2 for the constant work rate cycling test. And you can see overall, the agreement was either moderate, good, or excellent for all those variables. And if you look at the mean differences, most of them were always around 0, which means no difference or very little differences if you look at the confidence interval. You have some variables which the difference was far from 0, let's say, for instance, right rate and minute ventilation, but the discussion is these differences, they are not meaningful in the term of impacting how we assess endurance time or assess the efficacy of the interventions analyzed. Just to clarify, this is all patients, either from pharmacological studies or exercise training studies, because only data from baseline is being used for these. This figure is still to describe the constructive validity, but to show whether the test can differentiate between groups. So what the authors did, if you look at the x-axis, you have patients classified as very severe COPD, or moderate to mild COPD based on FEV1. And then blue bars, it's data from studies, from exercise training studies. Yellow bars, data from bronchodilator studies, including the active arm only, so only patients using the real medication, excluding patients that were randomized to the placebo. What you can see if you look at exercise training improvements in endurance time, shown in the y-axis, they were similar for either very severe, or moderate and mild COPD. But when you look at the effect of the change in endurance time for the very severe, and moderate and mild severe COPD patients, for the bronchodilator arms, you can see for patients with very severe COPD, the improvements were much larger. And the discussion here is bronchodilators are supposed to target or to lead to greater improvements for patients that have a ventilatory limitation during exercise. And that's why you see larger improvements for the very severe COPD patients compared to the severe or moderate and mild COPD. Also, for the constructive validity, they look for the relationship between the endurance time from the constant work rate cycling test and the responses during the maximum exercise test, the maximum incremental here peak work rate, and the maximal, the delta oxygen uptake from the maximal, from the incremental test. And then they show moderate correlations between the delta in endurance time and the delta in peak work rate or oxygen consumption, again showing the constant work rate cycling test is associated here and supporting it has a good constructive validity. On this table, you see now on the right side, you have the correlations between the change in constant work rate, endurance time, and the change in and exercise constant work rate variables. So they look, for instance, for the change in time and the change in bark dyspnea, change in leg fatigue, change in right rate, respiratory capacity, minute ventilation, oxygen uptake, tidal volume, respiratory rate. So first, they show for patients randomized to the active bronchodilators arm of the bronchodilators study, patients with FEV1 less than 50%, patients with FEV1 more than 50%. Last column show data from exercise training studies. So N is the number of patients and then the relationship. What they are looking here is the delta change in endurance time, is it associated with the delta in bark dyspnea? And you can see the correlations are weak to moderate for the three groups. Patients randomized to the active bronchodilators FEV1 less than 50, more than 50, or for patients from the exercise training, and they say, okay, but this is the correlation between the delta in the endurance time and the delta in the response during the constant. That can mean the patient cycled, for instance, 5 minutes and then did an intervention, and then he was cycling 7 or 8 minutes. So is it fair comparison? Maybe it's not. What they say is the fair comparison actually would be if we compare the change in responses at ISO time, which is the patient is doing the same load over the same time after an intervention, and the change in endurance time. So does the change in endurance time reflects or associates with the change in the perceptual and physiological responses at ISO time? And then they find moderate, again, weak to moderate correlations, but the correlations were stronger than when you compare to response at peak exercise. So supporting a good constructive validity for the test. Next, they look at reproducibility. When they look at reproducibility, they look the retest reliability reflects the ability of a measure to give reproducible results in clinically stable patients. So what they did here was they focused on the reproducibility for the change after an intervention, not the reproducibility at baseline. So they look at the 2 post-intervention tests that were separated by 3 to 6 weeks. So for instance, they take a bronchodilator study, the patient did a baseline, constant work rate cycling test, 6 weeks of intervention, repeated the constant work rate cycling test, and then he had a second constant work rate cycling test after the intervention. So are the responses, are the two constant work rate cycling tests performed after intervention, are they reproducible? So they separated again for patients randomized to the placebo arm of bronchodilators, and then patients randomized to the active arm of bronchodilators with FEV1 less than 50% or FEV1 more than 50%. They do not report data about exercise training studies because there was no exercise training studies with two constant work rate cycling tests after the intervention. First column here, they show the endurance time for the primary time point, that's 6 weeks after the intervention, and the delta endurance time at the alternate point, which means around the time after the 6 weeks. Next column shows the difference between the two tests, and which were not statistically significant for any of the groups. And you can see, even if you look, the largest difference was less than 1 minute, less than half a minute, which means less than 30 seconds. The agreement was good, again, between the two tests, so showing that the delta time of endurance time, so the reproducibility of assessing responses with a constant work rate test was good. For responsiveness, they look at the degree to which an instrument is able to measure the change in the construct to be measured. So what they did here is they compared the differences in the mean endurance time from the constant work rate cycling test between baseline and the end of treatment. So again, first line, they have data from patients randomized to the placebo of the bronchodilators studies, then patients randomized to the active arm of the bronchodilators study, and once more separated by patients FEV1 more or equal 50%, patients FEV1 less than 50%, and then patients that were data from exercise training studies. Number of patients. First column is the duration, the endurance time of the baseline test, so before intervention. Next column is the duration of the test at end of treatment, so after the intervention. Then we have the difference between the two tests, pre and post intervention. You can see there is no statistically significant difference for the duration of the test, pre and post intervention, for patients randomized to the placebo arm of the bronchodilator studies. However, if you look at patients randomized to the active arm of the bronchodilator study, doesn't matter if FEV1 more or less than 50%, or patients going through exercise training, there was a statistically significant increasing in the endurance time from the constant work rate cycling test. It's also nice to see that this response was, the effect size was almost the double for patients randomized to the active arm of the bronchodilators study if you compare for those with FEV1 less than 50% compared to FEV1 greater than 50%. Again, the rationale here is that bronchodilators are targeting ventilatory limitation. So the patients, the more severe patients are more prone to have ventilatory limitations. And then if you look at the effect size for exercise training, it's almost the double, which was for the patients with more severe COPD. So meaning effect size increases here from bronchodilators to the exercise training, almost doubling it. They also address interpretability, which means, so this is kind of tricky, the degree to which a human can consistently predict the model results. So it means, okay, we expect this intervention to improve endurance time. Can the test I'm proposing or they are proposing measure it? So what they did, they selected several anchors that have previous published MID, so minimum important difference. And they say, let's see if the endurance time from the constant work rate cycling test is associated with those anchors which have been shown to provide the minimum important difference in the literature. So this is just for studies involving bronchodilators first. I will show exercise training next. So for studies involving bronchodilators, they use two anchors. They have two others as exploratory analysis, but they use the delta isotime inspiratory capacity and the reduction in Borg dyspnea. So they show that the change in endurance time is associated with the change in inspiratory capacity and the Borg dyspnea, and the correlation was greater than 3, which was the cutoff they used. Then if we see here if you follow my pointer, you will see the anchor MID, which means a change of 0.2 liters in the respiratory capacity at isotime, or a reduction in the 1 unit of the Borg scale at isotime. And then according to these two anchors and the MID previously proposed for those two anchors, the MID for the endurance time range from 1 to 1.2. And this is for the just bronchodilators study. If we move to the MID estimates according to the exercise training studies, again, we have here the anchors they found in the literature, which was the change in the peak work rate, the change in oxygen uptake, again, change in respiratory capacity, and change in Borg dyspnea. So again, the correlation was above 0.3, which was the cutoff they chose or they used. And then you have here the value, the MID for each of the anchors. So for watts for the incremental peak work rate, 0.04 liters for the oxygen uptake, 0.2 liters for the delta IC at isotime, and a reduction of 1 point in the Borg scale at isotime. And the estimated MID for the endurance time, again, ranging in this case from 0.7 to 1.4. When they put all of this together, so figure 2 here, you can see on the left side for the bronchodilators study, on the right side for the exercise training studies, the average value was 1 minute. So the proposal MID from their data is a 1 minute change after a given intervention. Lastly, talk about interpretability. They did a responder analysis. So can the test detect how many patients are improving and how much they are improving? So if you look at the figure on the right side, you have in gold data from the patients involved on the exercise training studies. Blue, patients randomized to the active arm of bronchodilator studies, FEV1 less than 50%, and purple, patients randomized to the placebo arm of the bronchodilator studies, FEV1 less than 50%. The table on the left show more or less the same message, but then you have here in the lines the data from patients randomized to the placebo arm of the bronchodilator studies, patients randomized to the active arm of the bronchodilator studies, both group FEV1 less than 50%, and then patients from exercise training studies. They have different cutoffs for improvement in endurance time. So first, those patients, how the proportion of patients improving more than 1 minute after the intervention, improving more than 2 minutes, more than 3 minutes, and more than 4 minutes. What you show is, if you look for larger improvements, let's say if you compare the number of patients improving 1 minute to improving 4 minutes, you see there is a reduction for the 3 interventions. But when you compare the interventions, you see the patients on the placebo compared to the patients randomized to the active arm of the bronchodilator studies and exercise training, you have an increased number of patients proportion of patients achieving the target here. Doesn't matter if the target is less, it's less, let's say an increase of at least 1 minute, or if the increase of this 4 minutes. So you can see the test can detect the improvement, and it's different for the 3 interventions. And it's sad again, why this could happen, or why is this expected? Because here patients on the placebo, they should not improve or improve less because they are receiving no intervention. Patients with FEV1 less than 50%, those prone to have ventilatory limitations, receive a medication, they should improve. So a larger proportion of these patients should improve the endurance time compared to patients on the placebo arm. If you look at the exercise training, then you think exercise training is it's supposed to improve endurance for those patients with ventilatory limitations, but also for those patients without ventilatory limitations, since exercise can also improving muscles. So it goes in line, this increasing the proportion of patients according to the intervention goes in line with what was the hypothesis or the rationale for using this test as an outcome measure. So just to conclude, the authors bring that the measurement properties presented in the paper build on previous work and add further information or evidence that increased constant work rate cycling endurance time in COPD clinical trials implies improvement in exercise endurance. They also bring that given the exercise endurance is a meaningful aspect for the health of COPD patients, they believe that the endurance time from the constant work rate cycling test can be a valuable performance outcome measure in support to evaluation of treatment benefit in the context of regulatory and clinical decision making for the COPD therapy. So thank you, and I'll give the floor again to Dmitry and Mariana. Thank you so much.
Thank you, Antenor, for that excellent overview of the paper and the figures and summary as well. So we'll go to the floor for questions for Antenor and the authors, and Mariana will also have some questions as well. And Antenor, if you don't mind keeping some of these slides available for sharing, because I think the tables and figures will be very beneficial for the discussion for this type of paper. So do we have any questions from the floor, comments or questions from the audience? Thanks everyone for joining. And so you can also put the questions in the chat. So while we wait, maybe I'll go to Mariana, as I know she prepared some questions. Mariana, did you have some questions?
I actually do. It's probably more of like curiosity in terms of, I would confess that I didn't go back and check all of the studies in exercise training that was included for the patients. I have to confess that. But I was very curious if the authors had an idea if those studies using exercise training mainly were pulmonary rehab, and if it was, were those patients training in exercise bikes? Obviously, because we see a triple effect in responsiveness. So was this kind of like expected when you see that? And that goes as well for, you know, when you're evaluating the construct validity, for example, was it expected that you would see a less agreement in the BOG for dyspnea, for example, and for effort, because, you know, you're comparing a peak exercise test to a constant test. Like, were you guys expecting to see less agreement because of the percent of the load you're using on the test, or like you expect that the BORG for dyspnea and effort will be the same? Sorry, but just two questions in one. But
Great. Did Professor Casaburi or Dr. Alan Hamilton want to take that?
Why don't you start, Alan? I have to unpack the question.
Sorry, Richard, you want to go first, or you want me to go first?
You go first.
So maybe Marion, can you just, I think you had two parts, maybe just repeat the first part? I think it was what type of training was
yeah, because I actually didn't check all of the exercise training studies, but were those training more related to pulmonary rehab, and were those patients doing cycle exercise, or they were doing any type of exercise training?
So across all the studies, and I think Rich could probably give more details, because some of the studies were his studies. Certainly, I believe that they certainly did incorporate cycle training, I think the vast majority of them, but it was probably in addition to that other types of training as well, such as resistance training. But from my understanding of the studies, I think that from the point of view of the endurance training, they were, I can't say 100%, but I think the majority of them, if not 100%, were conducting exercise training on a bike.
You know, my memory is a little bit different, Alan. We certainly didn't restrict the entry of studies to one specific kind of exercise training modality. I think it speaks to the really sort of protean effects of rehabilitative training, which always include training of the legs. And while there is some specificity of cycle versus treadmill, both of them strengthen the legs and will generally produce improvements in exercise endurance when done on a cycloergometer. So I think we should take a lot of pride in the fact that rehabilitation works so well. And again, better than bronchodilators. We love bronchodilators, but even in the very severe groups, the exercise training did better than the bronchodilator.
Yeah, absolutely. That was very, very great to see.
And then the second part of your question, please.
The second part was more if you guys were expecting to see less agreement in between the BORG for dyspnea and for effort between the peak exercise test and the endurance test.
No, I think we expected to see similar results. We were really pleased to see that the results were so similar. But the idea that this is a very clear demonstration that the constant work rate endurance test is a maximal test because it gives you perceptual and physiologic changes that are similar. Now, let me digress a little bit, and this is referred to in the paper, and it's a major section in the supplement. We also compared both the constant work rate and the incremental test to 6-minute walk results. We had a considerable number of studies that also, that they all, as well as doing incremental and constant work rate, they also had 6-minute walk tests in their subjects. And you look at the maximum responses of 6-minute walk. Now, we don't have oxygen uptake. We don't have isotime BORG score, isotime ICs, but we do have often heart rate and BORG dyspnea and leg effort. And the 6-minute walk is considerably lower. That 6-minute walk is not a maximal test. And in my universe, that means it's not a good test to look for changes in exercise endurance. It's influenced by motivation and practice and things like that. It's not a maximal test, which is why, in fact, if you there's another paper that was published several years ago looking at 6-minute walk testing, showing that it was a very good prognostic indicator. You had a low 6-minute walk, you died and had exacerbations and stuff like that. But if you were looking at the response to interventions, 6-minute walk didn't work. If you looked at a response to a bronchodilator, 6-minute walk distance didn't change after bronchodilator. Again, because it doesn't test the patient's physiologic ability to do stuff. It tests perceptual and motivational sort of aspects. That's a long-winded response. Alan, you have something to add?
Thank you.
I think the point, I'm glad that Antenor focused on the previous paper, the conceptual model paper, because very much that was foundational for the way that we approach the validation and the construct, especially the construct validity part. And that's, if we just think about this in the regulatory environment now, and especially with the FDA, and actually in parallel to the work that we were doing, because this was a very long project that we were doing. And as we were moving along with the project, the FDA actually brought through their patient-focused drug development initiative and guidances. And one of the things that they've separated is the conceptual model and the measurement model. And a way to put that in layman's terms is make sure you understand what to measure and how to measure it. And I think that was very much aligned with what we did in the conceptual framework to make sure we didn't just say, oh, we're measuring exercise capacity, but actually to say what aspect of exercise capacity are we measuring. And I think that would probably be something that we would advocate going forwards, is that when we look at all the different exercise tests that are available, not simply to say they're all measuring exercise capacity, but actually what kind of dimension. And I think when we talk about the constant work rate cycling versus the 6-minute walk test, I think if we do understand what the difference is, what is actually being measured in those two tests, then I think we can take the results of those two tests, which should actually be very informative. One is probably telling us about capacity. The other one is more about the ability to translate that capacity into performance in everyday life. And so I think that if we're clearer on specifically the concept, the health concept that we're measuring, then I think we can get added value from looking at these different tests together.
Yeah, thank you for those responses. Maybe we'll go over to Sana, who has a comment in the chat. I could certainly read it out, but Sana, if you're able to speak up, and we'd love to hear from you. You can ask your question. Just let me know if you're able.
Hi, yeah, I'm here.
Thank you.
Yeah, so I have done some reliability studies, and my understanding is that this retest reliability should not represent a change in the instrument. So when you test the reliability of a device, you should not say that it is we measured the change in the instrument or in this device. Reliability should represent that when you repeat the test, there should not be any change between the first and second time of the measurement. So I'm not sure why in one slide he said that we examined the change in the instrument when we tested the reliability. The other question was how did you choose the time for reliability test? I think 2 to 3 weeks, maybe a long time for a retest. How did you make sure that the patients will not change after 3 weeks of exercise, like when you repeat the test after 3 weeks? Thank you.
Yeah, Rich, do you want me to have a first stab at that? Because actually that brings up I think actually an interesting discussion point we had as we were developing the plans for the analysis, and can actually refer back to some previous work that was done on test retest in a study. I think it was Dennis O'Donnell was the first author, where we actually looked at reliability at baseline. So we generally what has been done with these types of tests, especially in the bronchodilator studies, is there would tend to be 2 baseline measurements to take care of any learning effects. And so traditionally then the test retest was done at baseline. But as we were considering this in the context of measurement properties for use in clinical trials, we recognize that actually the more appropriate way to look at that in terms of measurements for interventions was actually to look at a time point post-intervention. And we chose, I think, 6 weeks because that has generally been the certainly in the exercise, the bronchodilator studies, that has been the time point for the primary endpoint in many of these studies. So to be able to look at reliability from the point of view of baseline versus 6 weeks to see if we are getting stability in those measurements was most appropriate for the context of use of these measurement properties within clinical trials of 6 weeks duration, 6 weeks or longer duration.
Let me just add, the choice of the time points that we evaluated were sort of pragmatic. It's what we had. Fortunately, a number of the studies did look at more than one time point post-intervention. And the point is, for a bronchodilator, the effect of the bronchodilator is sort of steady state after a week or so, even for the long-acting bronchodilator. So any time point after that could be considered to be steady state for the pharmacologic effect. Now you say, well, what if the patient's condition changes over those weeks? And of course, that's true. There's variability in that, but that would only tend to degrade the agreement. We saw a very, very strong agreement, so we were encouraged by that fact. Was there some other nuance that you were trying to get at, Sana?
No, it's like because I'm reviewing some RCTs for COPD bronchodilators, and I saw that some patient improves earlier than 3 weeks. So I was not sure if it is suitable to wait until 3 weeks to reevaluate and then to judge for the retest reliability. So, but if you think that this time frame is enough for a retest reliability and the patient won't change, that's it's up to you. It's I'm not sure. Because the studies used up to 2 weeks, to test for the reliability, but not sure if you're using also bronchodilators, how that will affect this test retest.
Well, I'd point out we not only have data to that effect in people who received bronchodilators, we have data to that effect in people who didn't receive bronchodilators, in other words, received placebo. and the results seem to be pretty robust. So if you don't like one, there's the other.
Yes, thank you so much. Thank you.
Thank you. Thanks for clarifying that. So maybe we'll move on to some other questions from the audience. Thank you, Sana, for that question. Any questions from the audience in the chat or with hands up? If not, I have a question, but also would like to give the presenter, Antenor, a chance to see if he had any questions. Antenor, did you have any questions for the co-authors?
I'm just curious now whether or not they could get FDA to accept the outcome for clinical trials.
I'll try one. Alan's really the regulatory expert here, but I want to recount an experience that I had. Alan was there too, on why we had to go through this process. It was well more than 10 years ago that I was asked to come to an FDA panel in support of one of the new bronchodilators. Was a Boehringer Ingelheim product, and the bronchodilator worked fine and it was approved, of course, but we wanted to see if we could get them to agree that the bronchodilator improved exercise tolerance. No product has that indication, yet we all know that bronchodilators improve the ability to do things. So I was there and I presented this really lovely data on constant work rate exercise testing, improvement in endurance time. It was greater than what we thought the MCID was. And the rockets went off, and I sat down, and they said, "Well, what does that mean to the patient?" And we had to say, "Well, we think this is relevant to the patient, but So it was clear that we needed to establish patient relevance, and the first paper that we published in this series was aimed at trying to establish that. We established the equivalence between a given work rate and a constant work rate test and an activity the patient might do, that 46 watts was equal to walking at a level pace at 3 miles an hour or something like that, and established strict patient relevance for the outcome. Again, Alan will explain the nuance of why this hasn't been accepted by the FDA as a result of this endeavor, but may in the future. Alan, you're up.
Alan, if you can answer the question in the chat as well. Just a reminder that the presentation is being recorded and will be posted publicly. This extensive work aims to validate the constant work rate as an outcome with the FDA. How's that going? Question from Lorna. If you can try to answer that as well. Thank you.
Yeah, and actually, I'll speak a little bit to my previous life with Boehringer Ingelheim and the work that was done. And what's interesting there is if we're talking about the FDA and getting into label, but in actual fact, for many years, with the first studies that we performed with Spiriva, tiotropium, we actually were able to get the information from those cycle tests into the European label. So that was about 20 years ago. But with the FDA, I think one of the challenges has been maybe focusing on the instrument, the measurement instrument, and not the measurement, the concept of interest. And I mentioned a little bit about patient-focused drug development. So a lot of the discussions tend to be on, is this instrument, should the data from this instrument be included in the label or not? What's missing there is that first part, and I mentioned a little bit about the what to measure. And as Rich said, when we went and had discussions with the FDA, the focus tended to be on, is the constant work rate cycling endurance time appropriate for being included in the label? There can be arguments for and against that. What I think has been missing there is to say, well, is exercise endurance a concept that is meaningful to patients? And now that I'm working actually for a patient organization and we speak to patients, and that becomes very evident. In fact, recently had a patient asked about what are they looking for from new medications, and the lady came up straight away and said, I'm looking for more endurance. And I think that in order to move this forward, I think that's where patient-focused drug development may be an opportunity to progress in this area, is before we actually talk about which instrument to use, the how to measure, we need to get an agreement on what are the appropriate health concepts to measure. And so I think that the way forward is to have an agreement with all stakeholders that health concepts such as breathlessness and exercise endurance are important measures that need to be measured. And then we can then debate about which is the appropriate measurement instrument. I think that's probably what has been missing in the past and where we need to go in the future.
Thank you for that overview. Any other questions from the audience? In the meantime, I was hoping to ask a question for Alan or Rich. With regards to the clinical implications or applying this in the clinical setting outside of research, oftentimes, and for evaluation of dyspnea of unknown etiology or determination, we use an incremental exercise test, whether it's a 6-minute walk or a cycle ergometer. Just wondering your thoughts. I know you commented briefly on it towards the conclusion and discussion in the paper, but how could we roll this out in the clinical setting? And just want to get your perceptions.
Well, I think that the infrastructure, the sort of conceptual basis for doing incremental exercise testing to exhaustion on a cycle ergometer with measurement of ventilation, gas exchange, and cardiovascular variables has been very well established and as a diagnostic technique to determine the etiology of exercise dysfunction. To quote Carl Wasserman, this is all geared together, and we can spy from these measurements what's wrong with the muscles, heart, lungs, and that is expanding now with Dr. Rossiter's muscle test. There's a very firm understanding of how these variables relate to exercise pathophysiology. Here we're talking about something that's somewhat different ways of assessing improvements that occur in patient-relevant ways to an intervention. Different sort of contexts, both important in their own right. Alan?
Yeah, I mean, I think one thing that is still required. I remember having been involved in these types of tests for many years, and one comment that comes is always a challenging comment, which is, this is all well and good, but patients don't cycle. And I think that so on the one hand, what some people are expecting is to have a measure of physical activity that is something that patients do in their everyday life, walking or climbing stairs or doing gardening. The problem with that is that if you choose one for one patient, it might not be relevant to another patient. And I think in order to be able to translate this into the clinical setting, and that's what we tried to do in the first paper, was try to establish what types of activities in everyday life are similar to what is being done, and not to think of it as cycling, but as muscular work that is creating a cardiorespiratory or requirement for cardiorespiratory support. So I think in the clinical setting, that is still work that needs to be done, is how to effectively translate the information that we gain into something that will be understood by patients, so the connection with what they are doing in their everyday life. But I do think that's an important next step to take, and to try to get across this understanding that it is not necessarily the specific activity that's being done, but rather the physiological support that is required in order to be able to perform that activity, to be able to create that translation.
I'd like to say one more thing, and I have to say it carefully, make sure I don't mess it up. We're not saying here that we think that all patients undergoing a bronchodilator or an exercise training or any other intervention should necessarily have a constant work rate test to evaluate the value of that intervention in the individual subject. This is for subject groups. This is for regulatory sort of approval. This is in large studies. It turns out the variability in endurance time is appreciable by looking at the responder curves. You can see that, and that not all patients who get a positive response will have an improvement in the exercise time, but as a group, they will, and it's a discriminative intervention. So we're not saying that everybody who does a bronchodilator should have constant work rate test. We're saying that if you want to validate that a given intervention works, a group of subjects performing this test will be discriminative.
Thank you. And this blends in nicely with Astrid's comment. She says, thank you for this nice work and presentation. I was wondering if the authors were surprised about the minimally important difference results. I think it's lower than previous results on the minimally important difference that you guys highlight in the paper as well. And maybe just to follow up to this, I'm wondering if there was any correlations you had data on activities of daily living through questionnaires that you were able to integrate with these results.
The second part, we didn't have any of those sort of questionnaires in our database to evaluate. In terms of the minimum important difference, this is a very, very slippery topic, I must say. It's very difficult to sort of conceptualize what a clinically important difference, and anchoring it to other clinically important differences is difficult because those may not be well established either. It's all sort of castles in the air. It's relative to what? It's relative to a perception, and it's difficult. We were very pleased that we got fairly consistent results among a whole bunch of ones. Nobody's ever looked at as many anchor variables in the past. And the fact that they were reasonably consistent was pleasing. It is somewhat less than has been previously postulated. Usually a minute and a half, a minute and 3/4 has been cited. But even the confidence limits we have here don't preclude those estimates either. Alan?
Yeah, and then I think just to add to that, I think Antenor showed that in the last results was not only looking at the information on a specifically defined threshold, the MID, but also looking at the cumulative response distributions. I mean, that tends to be actually where authorities such as the FDA have tended to focus their attention. So to show that taking a series of thresholds, you're seeing consistent results across those different thresholds in terms of improvements in with the intervention. So yeah, as Rich said, I think going into it, there is a bit of a chicken and egg, because with the metric that you're looking at, you have to find other metrics that you're anchoring to that have MIDs, but you go back and think, well, how did they come up with the MIDs? And well, they needed to find an anchor. So it is a chicken and egg, because it's like, what is the first anchor that should be used? But I think overall, though, we are seeing consistency. We're showing relationships as we would expect those relationships to be, and then finding I think certainly people like Paul Jones, who has done a lot of work on MIDs, would say we need to be careful about taking these as absolute critical thresholds, but rather think about it as almost like a point along a line. It gives you some sense of a range, but don't take it literally as a singular MID threshold.
I might mention that the journal was kind enough to let us put a fairly long section in our supplement where we sort of discuss where we found the MIDs for these other variables, and different people quoting different values. So it's a sort of cautionary note in a way.
Yeah, thanks, Astrid says. And there's a last question, and before I turn over to Marianne to close the session, because we're getting close to time. Question from Lindsay in the chat. She congratulates Antenor for a great presentation, and to the authors. And a question about the endurance shuttle walk test. Do the authors think it may be a more practical choice than the constant work rate cycling test in clinical practice? Did any of these studies you looked at include this outcome?
In fact, they did, and this project, in fact, included shuttle walk as an alternative outcome. It is likely a maximal test. It's the way it's conducted should be a maximal test. And actually, that database is sitting, waiting to be analyzed. It more practical certainly does have easier to perform, less technological, less insight because you're not measuring a whole bunch of things. But the endurance shuttle walk is another good measure of exercise endurance. We believe, although it hasn't been analyzed as rigorously as the constant work rate cycle.
Yeah, I did just add to that. Rich and I were authors on a publication a few years ago where we actually, in studies, we had included both constant work rate cycling and the endurance shuttle walking test, and we actually wrote a specific paper comparing and contrasting the measurement properties of those two, and we found actually they were very similar. And I think it's not to say that one is better than the other, but look at the context of the clinical trial. I think there are some clinical trial contexts where the endurance shuttle walk test may be a more feasible test. Others, especially if you're looking for more physiological, and a lot of the studies that have been done with bronchodilators have not only looked at the functional performance, but also looked at physiological mechanisms. And so I think that I very much like the term fit for purpose. I think that depending on the context of the clinical trial, one or the other would be very viable. But as Rich said, it would be great if we can do the same. I mean, we have the database, and it's just finding resources to be able to move forward with the similar type of approach for the endurance shuttle walking test.
Thank you, everyone. And go over to Mariana for closing remarks. See everyone at the ATS.
I would just like to thank the ATS and obviously Antenor for a very clear presentation and brilliant presentation of this paper. And thanks for the authors for taking the time to talk to us about the paper, and thanks everyone for joining in.
Great. Thank you. And see everyone in San Diego if you're going to the ATS. Look forward to it.
Thank you. See you all.